Chapter 30, Multi-System Trauma. So, we're going to be talking about multi-system trauma, more than one serious injury, one or more injuries serious enough to affect more than one body system. This requires teamwork, timing, and transport decision, which are proper to take care of this patient. Some of our most critical decisions with these patients are going to be determining their priority and severity, whether to limit scene time or to stay and try to perform treatments, and which hospital or transport method is best for our patient. So we're going to be going by ground, we're going to be going by air, do we need an ALS intercept? So, some physiological criteria. And so I think this is going to be referring to some of them CDC things that I mentioned in your review email, right? Some things to look out for. So when to go to a trauma center, I believe is what we're talking about here. Altered mental status with a GCS of less than 14 could indicate a head injury. Hypotension, shock, internal bleeding, systolic less than 90, abnormal slow respiratory rate. Don't quote me. I think this may be with the CDC things I was talking about, but don't quote me on that. I'll hit that in our overall review. Okay. So penetrating injuries to the head, neck, torso, and extremity, proximal to elbow and knee. This is some determining severity. Chest wall instability or deformity, 2 or more long bone fractures, all things that are going to indicate we need to be going to a trauma center. We have a critical patient. Crust, degloved, mangled, or pulseless extremity, and amputation proximal to the wrist or ankle. Pelvic fractures, any open or depressed skull fractures or paralysis, all big indicators, right? So, there's also this thing we look at as mechanism of injury. We don't look at it as much these days as we used to, but it is still a factor. So in absence of anatomic or physiologic signs, is the mechanism of injury severe? Did they roll off of a mountain, flip around 18 times and smash down at the bottom? And even though the patient's up walking around, that would be a huge mechanism of injury that we need to check out. Would you look at that mechanism of injury? So falls, intrusion, ejection from an automobile, anytime there's death in the same passenger compartment, vehicle telemetry that's consistent with high risk of injury. These are things that we need to be taking these people to trauma centers. We need to be looking at that as an indicator that they may have hidden injuries that we don't know about. So we need to get them going to the correct facility. So, what patients are we looking at? What populations are we looking at? These are older adults who do not efficiently compensate for shock. Are they children that need to go to a pediatric facility? Are they taking blood thinners? Are they on Coumadin, warfarin, Eliquis? Are they on something that's going to help them not clot, which could cause them to bleed out, right? Are they pregnant? Do they have any other special factors that make us say, ooh, I'm really scared to send you home, right? So these people need to go to trauma centers and get checked out. So how do we manage these patients? So we got to practice with our crews. We got to role play. We got to determine our roles ahead of time. So we're en route. Hey, this is what I'm going to do, and this is what you're going to do. We're going to make sure we have a safe scene. Okay, there could be passing traffic. That's one of the scenes that worries me most. MVCs, because we can't always control every aspect of what everybody does. We can't control those drivers that are flying past us. So that does concern me because somebody could be doing the looky-loo and swerve over and kill one of my folks, right? That concerns me. Penetrating trauma. Maybe the assailant's the best friend. And then, or the husband, wife, girlfriend, boyfriend, whatever. And now they see you saving their friend and they want to kill you too. Okay, maybe they play nice when you first get there and act like everything's fine. And then the next minute, they got a gun out. So make sure your scene is completely secure. So a typical call, we're going to perform primary assessment. We're going to ensure an open airway. We're going to perform urgent or emergency moves, transport, give a report to the trauma team at the emergency department during our handover. Okay? So critical injuries, we're going to follow priorities determined by assessment. We're not going to delay transport by performing treatments that would waste time, especially as EMTs. We need to get going. It's our main priority. We're going to show good judgment. We may postpone taking vital signs until we're en route, if that's appropriate. We may give the give the hospital plenty of time to prepare, give them a heads up. Hey, we're a BLS crew. We're inbound with a 20-minute ETA, and we're coming to you hot with X, right? So follow your priorities determined by your assessment. So if you notice an airway line threat, you're going to stop and treat it, okay? Tend to immediate threats, reassess what to treat on scene and what needs definitive care, and call that hospital so they can have plenty of time. Depending on our assessment, we may postpone taking vital signs. Like, we may look at him and be like, this guy is gray, he's bleeding, we gotta go. And so we might slap on some tourniquets and hit the road and get vital signs en route, because we know they're not gonna be good. But we also know every red blood cell counts, and we don't want to lose those. So we may just pop on a tourniquet and get going. So as you reassess your patient in the vehicle, call the hospital. We talked about that. Update them with vital signs. We want to limit scene treatment to C-spine, suctioning, maybe an oral and nasal airway, restoring a patent airway, ventilating, high concentration oxygen, control bleeding, immobilizing the patient. Our scene safety is paramount. We got to make sure that we have an open airway. Have to perform urgent emergency moves if necessary. Adapt to every situation to overcome. We could talk to you about a million situations, and the first call you get on, none of them will work, because every single call is different, every single day is different. That's the beauty of EMS. Nothing's ever the same. So trauma scoring. There's a numerical rating system for trauma. Assigns a number to certain patient characteristics to create a score. It's supposed to objectively describe severity, helps determine transport to a trauma center, helps trauma center evaluates the care of similar patients. Then there's a revised trauma score, or RTS, okay? Takes into combined the Glasgow Coma scale, the systolic blood pressure, and the respiratory rate, okay? I don't see the trauma score or the RTS being used very much, but you do need to know individually the Glasgow Coma score and how to calculate it. You need to know systolic blood pressure, respiratory rates. So, there it is. Don't worry about this, guys. For your test, this is not important, other than to know some concerns. So what is our normal respiratory rate? 12 to 20. So 10 to 29 is outside of normal. That is a concern, okay? Systolic blood pressure under 90 is a concern, okay? And then your GCS, you just need to know how to calculate a GCS. So there might be a test question that asks, what kind of respiratory rate would the CDC show as a concern? And you would say, well, it's not 12 to 20 is normal. 10 to 29 is the next thing, that's not normal, okay? Or systolic blood pressure, okay? Yeah, we don't need to see this. All right, so that is multi-system trauma. Hopefully you got a little bit out of that. Oh, here we go. So the CDC has issued guidelines for trauma triage and transport. These are a guide and should be used in conjunction with your protocols. This test asks questions about the CDC guidelines. And I've been trying to throw those at you, but you need to know those. So make sure you're paying attention to those and you're working through them.